It's a pleasure to be with you. The title of this session is Schistosomiasis and Global Health. There are no disclosures for this presentation. Objectives include review the concept of DALYs as they relate to global schistosomiasis, review the life cycle of schistosomiasis, discuss the 3 determinants of human infection with schistosomiasis, review the concept of selective public health and its relationship to schistosomiasis transmission, review schistosomiasis disease syndromes, diagnosis and treatment, review the 6 major prevention measures to control schistosomiasis, and emphasize the importance of a comprehensive approach to control schistosomiasis. This table presents the global burden of major parasitic diseases. The global burden order is determined by their DALY's impact in millions. This session will focus on schistosomiasis or blood flukes with a disability-adjusted life year or DALY impact of 3.1 million. Schistosomiasis is estimated to cause 252 million new cases and result in 11,700 deaths per year. Let's take a few minutes to review the concept of DALYs. The disability-adjusted life year, or DALY, was first used in 1993 in the World Development Report of the World Bank. A detailed discussion of how DALYs are calculated is beyond the scope of this session. A DALY is a health gap measure. DALY is a measure of overall disease burden expressed as the cumulative number of years lost due to ill health, disability, or early death. The formula for DALY equals YLD, or years lived with disability, plus YLL, or years of life lost. The DALY relies on an acceptance that the most appropriate measure of the effects of chronic illness is time, both time lost due to premature death and time spent disabled by disease. The sum of these DALYs across the population, or the burden of disease, can be thought of as a measurement of the gap between current health status and an ideal health situation where the entire population lives to an advanced age free of disease and disability. The term infection primarily relates to diseases caused by fungi, bacteria, and viruses, and the word infestation more appropriately refers to diseases caused by more complex organisms like parasites. In practice, these terms are used interchangeably. Therefore, infection and infestation should be considered equivalent in this North Dakota Public Health Training Network Global Health Parasitic Series of talks. Schistosomiasis is also known as bilharziasis, is caused by some species of blood trematodes or flukes in the genus Schistosoma. The name bilharzia comes from Theodor Bilharz, a German pathologist working in Egypt in 1851, who first discovered these worms. Schistosomiasis is endemic in Egypt, exacerbated by the country's dam and irrigation projects along the Nile. As previously mentioned, schistosomiasis annually infests or infects approximately 250 million people in Asia, Africa, and South America, including 150 million in Africa, 32.7 million in China, Japan, and Indonesia, and 6 million in South America, as demonstrated in this world map of endemic areas for the various clinical manifestations of schistosomiasis. Gold and yellow on the map represent areas where hepatic, intestinal, and urinary schistosomiasis are dominant. Green areas, primarily urinary schistosomiasis, and brown areas, primarily hepatic and intestinal disease. There are over 400,000 people in the United States infected with schistosomiasis, mainly immigrants. The transmission of human schistosomiasis in the U.S. is impossible, since the United States lacks the necessary Snail intermediate hosts for transmission of schistosomiasis. The United States does have an endemic form of schistosomiasis, avian schistosomiasis, that cycles in birds. When the cercaria penetrate the skin of humans when swimming in infected waters, they develop swimmer's itch. These organisms can't complete their life cycle in humans. There are 6 major species that cause human disease, including Schistosoma mannsoni, Hematobium, Japonicum, McCongie, Intercalatum, and Guyanensis. The 3 main species infecting humans are Schistosoma Hematobium, Japonicum, and mannsoni. 3 other species, more localized geographically, are Schistosoma McCongie, Intercalatum, and Guyanensis. Schistosoma intercalatum is found in West and Central Africa. McCongie is found primarily in the lower Mekong River basin of Laos, Cambodia, and Thailand. Guyanensis was previously considered to be the same as Schistosoma intercalatum. There have also been a few reports of hybrid cattle schistosomes infecting humans. Foodborne trematodes or flukes are hermaphroditic, where each fluke contains both male and female genitalia. The blood flukes, or Schistosoma species, are dioecious, where male and female reproductive organs reside in separate individual flukes. This is a picture of male and female schistosome flukes with the female resting in a groove of the male body. This is a simplified diagram of the general life cycle of the Trematodiases. Eggs are excreted in the environment from a primary vertebrate host and enter a water source. In the water, the eggs embryonate and develop into miracidium within about 2 weeks. The miracidium hatch and swim to find an appropriate snail host. The exception to this is dicrocilium that infests land versus water snails. The miracidium penetrate the snail and settle near the site of penetration and begin the asexual cycle of reproduction. The miracidium then develop into sporocysts that produce daughter sporocysts. These daughter sporocysts produce more daughter sporocysts. This sporocyst replication cycle continues many times, progressively increasing the number of sporocysts within the snail. For foodborne tissue flukes, these sporocysts eventually transform into rediae and then into cercaria that emerge from the snail. These cercaria develop into metacercaria that attach to various food sources, as listed in this diagram. For schistosoma blood flukes, these sporocysts in an infected snail can transform directly into cercaria that cause infections for the primary host, like humans. This is a diagram of the schistosoma life cycle in humans. Schistosomiasis is caused by human fecal and urine contamination of waters containing appropriate snail intermediate hosts. Human infection starts with the active penetration of cercariae from contaminated water, generally lakes and other slow-moving water sources, the preferred environment for schistosoma host vectors. On penetration, these cercaria lose their forked tails and develop into schistosomulae. They then enter the bloodstream via capillaries and are circulated by the blood to the lungs and then to the liver, where they mature to adult male and female flukes and copulate. Adult flukes may occasionally be seen in ectopic sites throughout the body, including the lungs, intestines, brain, adrenal glands, etc. They then move on to the inferior mesenteric venules of the lower colon and rectum for Schistosoma mancini, japonicum, McCongie, intercalatum, and guyanensis. Schistosoma hematobium is transmitted to the venous plexus of the bladder. Eggs are then released into the tissues surrounding the adult flukes. The eggs mature in these tissues and are then released as embryonated eggs to the bowel and or urinary bladder lumen and excreted into the environment, where they hatch as miracidium and enter the snail and begin the asexual cycle of the organism previously discussed. This slide demonstrates the snail intermediate hosts and eggs of the 6 main Schistosoma species infecting humans: Schistosoma mancini, hematobium, intercalatum, guyanensis, japonicum, and McCongie. The major snail intermediate host for Schistosoma mancini is Biomphilaria, as pictured with the classic coiled shell. The embryonated egg of Schistosoma mancini has a prominent lateral spine, as pictured. The major intermediate snail host species for Schistosoma hematobium is Bulinus, with a corkscrew-like shell, as pictured. Bulinus is also the snail intermediate host for Schistosoma intercalatum and guyanensis in West and Central Africa. The embryonated eggs of Schistosoma hematobium, intercalatum, and guyanensis have a terminal spine, as pictured. The major intermediate host species for Schistosoma japonicum is Oncomelania, with an elongated corkscrew-like shell, as pictured. For Schistosoma McCongie, the snail intermediate host is Neotricula aperta, which has the same appearance as Oncomelania. The embryonated eggs of Schistosoma japonicum and McCongie have a small operculum, as pictured. The eggs of Schistosoma McCongie are smaller than those of Schistosoma japonicum. Schistosomiasis was first reported in the Mekong River's lower basin region in 1957, from the Laotian island of Kong to the Cambodian province of Kratie. Initially, it was felt that these cases were caused by Schistosoma japonicum until 1978, when the snail host, Neotricula aperta, was discovered, and it was determined that the schistosome was a unique species and subsequently labeled Schistosoma McCongie. Schistosoma mancini, intercalatum, and McCongie have a prepatent period of generally 6 to 7 weeks, with a range of 4 to 12 weeks. This prepatent period is the time from infection to when the parasite can be detected. For Schistosoma hematobium, the prepatent period is generally 10 to 12 weeks, and for Schistosoma japonicum, 4 to 7 weeks. The patency, or time the schistosomes are alive and producing eggs in the body, is generally 5 years for Schistosoma mancini and japonicum, and 1 to 2 years for Schistosoma hematobium. Occasionally, these schistosomes can live and produce eggs for up to 25 to 30 years, though that is unusual. An important point is that organisms producing large numbers of eggs released into surrounding tissues over many years can damage those tissues and result in many of the symptoms and signs of clinical schistosomiasis. Let's briefly discuss some basics of schistosoma epidemiology. Generally, there are three determinants of schistosoma disease transmission. 1, the number of infected humans. 2, the number of susceptible snails. And 3, human behavior, including fecal and urine contamination of water and occupational risks like fishermen, women who wash clothes in streams, etc. Schistosomiasis is associated with water projects, including dams and irrigation systems, which are great environments for snail intermediate hosts. Examples would include Lake Volta in Ghana, Lake Kanyiji in Nigeria, Lake Kariba in Zambia and Zimbabwe, and Lake Nasser in Egypt and Sudan. This is an example of a selective public health approach, which is often used as an alternative to a more comprehensive approach to address public health. Selective public health approaches can result in enhancement of the disease in endemic areas. Large bodies of water and irrigation ditches help solve public health problems associated with flood control, enhanced food production, and community water access. Yet without adequately addressing human waste disposal, sanitation behaviors, and water treatment, these projects may enhance disease spread, as with schistosomiasis. A major attribute of selective public health is reflected in the name, where select problems and projects are addressed. Immunization and basic clinical care programs provide another example of unintended consequences often encountered when selective public health approaches are used in place of more comprehensive strategies. To illustrate this, let's consider this simplistic graph. On the left side of the graph is the initial or early program period. A common selective public health approach in many global health programs is to initially and selectively focus interventions on immunizations and basic clinical care, since interventions like these commonly result in relatively rapid declines in infectious disease, morbidity, and mortality, improved pregnancy outcomes, and child survival as the programs progress. The lifespan of communities rise more slowly, as illustrated by the purple line. Increased lifespans are associated with an increase in chronic diseases. Currently, the major causes of morbidity and mortality in the developing world are chronic diseases. If other population-based issues such as food supplies and family economics are not adequately addressed due to the selective nature of these public health interventions, increased child survival may result in larger families, enhanced economic stress and poverty at the community and family level. This may result in families not having adequate resources to send their children to school. Poverty may increase family stress and dysfunction. Environmental stressors, like even a mild to moderate drought, can markedly increase the likelihood of food or economic crises in this situation. A famine may occur due to the tenuous nature of a food supply outpaced by community population growth. All of this can occur as a consequence of selective public health programs. Don't misunderstand what I'm saying. Selective public health programs like immunizations and basic clinical care should be used and commonly have a significant role to play in initially addressing pressing issues facing populations. But these selective public health programs should, as rapidly as possible, transition to more comprehensive, community-based public health approaches. In 1978, in Almaty, Kazakhstan, attributes of dealing with global primary health care and public health issues were outlined and included. Programs must be based on community needs. They must be community-owned and must be sustainable. They must be comprehensive versus selective. They must be culturally appropriate to be effective. And they must be accessible by all. A major attribute was they must be comprehensive. Though there are advantages and practical applications of selective public health, like the building of dams in Schistosomiasis endemic areas, a more comprehensive approach to public health issues is generally preferred, which mitigates many of the complications and problems encountered when selective public health becomes the primary tool of public health interventions. Children are vulnerable to infection with schistosomiasis, though the peak prevalence of infection is 15 to 25 years old. Children develop a progressive, slowly acquired immunity, including cell-mediated immunity and antibody, IgE and IgG2. The body's immune response to schistosoma infection, often a reaction to eggs released within body tissues, is responsible for many of the characteristic signs and symptoms of clinical schistosomiasis. The interaction between parasites and hosts is complex and often symbiotic. Symbiosis defines three basic relationship types occurring between living entities. One, mutualism, where both species benefit. Two, commensalism, where one organism benefits and the other experiences no harm. And three, parasitism, in which one entity benefits, sometimes at the cost of the other. Extensive research shows that parasitic worms have the ability to deactivate certain immune system cells, leading to a gentler immune response. Often, such a response is beneficial to both parasite and host, according to Professor of Medical Microbiology Graham Rook of the University College London. This immune relaxation is incorporated throughout the immune system, decreasing immune responses against harmless allergens, gut flora, and the body itself. Dr. Osada states that because parasitic worms may and often do consist of allergens themselves, the degree to which they pacify or agitate the immune response against allergens is a balance of their regulating effects and their allergenic components. Therefore, depending on both of these variables, some parasitic worms may not only benefit, but also worsen immune responses and complications in the host. In schistosomiasis, infection may reduce the severity of collagen vascular diseases due to immune modulation, demonstrating the concept of symbiotic mutualism as discussed in the referenced article by Dr. Osada. Detailed discussion of parasitic symbiosis is beyond the scope of this session. This table is from the World Health Organization and lists the distribution of schistosoma species. Schistosoma mansoni, japonicum, mccongi, intercalatum, and guyanensis are intestinal organisms, and Schistosoma hematobium is the species that primarily infects the urogenital system. Schistosoma mansoni is found in Africa, the Middle East, the Caribbean, Brazil, Venezuela, and Suriname. Schistosoma japonicum is found in China, Indonesia, and the Philippines. Schistosoma mccongi is found in several districts of Cambodia and the Lao People's Democratic Republic. Schistosoma intercalatum and its related species Guyanensis are found in the rainforest areas of Central Africa. Schistosoma hematobium is found in Africa and the Middle East. Let's consider some key clinical manifestations of schistosomiasis, including Katayama fever, intestinal syndrome, hepatosplenic syndrome, cardiopulmonary syndrome, central nervous system syndrome, and other ectopic sites of infection. Let's start with Katayama fever. Katayama fever is likely caused by the hyperimmune response to the organisms, symptoms and signs caused by our body's immune response to the parasite and the eggs passing into and through tissues. The picture on this slide is a hematoxylin and eosin or H&E stain of Schistosoma mansoni eggs in a tissue specimen. Katayama fever is primarily associated with infections caused by Schistosoma japonicum, mansoni, and rarely hematobium. Symptoms of Katayama fever generally occur from 2 to 8 weeks after cercarial penetration. Signs and symptoms of Katayama fever include fever with afternoon spikes to 105 degrees Fahrenheit, cramping abdominal pain, watery to bloody diarrhea similar to Shigella, weakness, cough, anorexia, nausea, vomiting, diaphoresis or sweating, myalgia or muscle aches, headache, weight loss, generalized non-tender lymph node swelling or adenopathy, tender hepatomegaly or enlarged liver, and an enlarged spleen or splenomegaly. Occasionally, patients with Katayama fever can present with palpebral edema or swelling of eye tissues, urticaria or hives, and purpura or skin hemorrhage. The adenopathy and hepatomegaly resolve with treatment in adults, but can persist in up to 25% of children. Laboratory findings in Katayama fever include a blood eosinophil count of greater than 90% and hyperglobulinemia. Anti-schistosomal antibodies are often positive. The eggs tend to be passed intermittently and in small amounts and may not be detected, so it may be necessary to perform a blood or serologic test. Symptoms of Katayama fever usually remit after 2 to 3 weeks, though occasionally it may take months for resolution. A small proportion of people have persistent weight loss, diarrhea, diffuse abdominal pain, and rash. Schistosomiasis can present with an intestinal syndrome. This is usually seen with Schistosoma mansoni and japonicum, but can also be seen with intercalatum and mekongi. Remember, these organisms have a tendency to mate and live in the mesenteric venules. Many patients are asymptomatic. Intensity of symptoms are associated with the intensity of the infection and may include abdominal discomfort, anorexia, and diarrhea. Growth retardation may be seen in severe childhood infections. The chronic inflammatory response to Schistosoma organisms may lead to granulomas, fibrosis, colonic papillomas, and polyps. Colonic polyps can progress to bowel cancer. Bilharzioma, or masses of granulomatous tissue, can mimic cancer and cause intestinal obstruction. The picture on this slide is of Schistosoma mansoni causing classical colonic polyposis in this surgically resected specimen. The patient was a 20-year-old Egyptian male. Hepatosplenic syndrome is most commonly associated with Schistosoma mannsoni and japonicum, but can also be seen with intercalatum and McCongie. Eggs traveling from the mating adults in the mesenteric venules travel to the liver, resulting in inflammation and fibrosis, also known as pipestem or Simmer's fibrosis, surrounding the portal venules. Symptoms and signs of the hepatosplenic syndrome include non-tender firm hepatosplenomegaly with esophageal varices that can result in hematemesis or vomiting blood, and melena or black stools due to the presence of blood from bleeding varices. Liver function remains normal or modestly abnormal since much of the liver parenchymal tissue or cells remain intact. The fibrosis occurs about the portal vessels, causing vascular back pressure, resulting in ascites and varices. Hyperglobulinemia is common in the hepatosplenic syndrome. Alkaline phosphatase levels are increased due to the involvement of the portal triad, including the bile ducts. This picture demonstrates adult worms of Schistosoma japonicum caught in a blood filter. Schistosomiasis can occasionally occur concurrently with bacteremia and result in liver colonization and subsequent liver abscess. This report from 2005 in the Royal Society of Tropical Medicine and Hygiene by Goldani et al. Demonstrated recurrent Pseudomonas aeruginosa liver abscesses in a Brazilian patient with chronic Schistosoma mannsoni. The liver abscess on the computerized axial tomography CT scan is the less dense area at the tip of the arrow. The urinary syndrome is primarily seen with Schistosoma hematobium. Signs and symptoms are caused by eggs in the bladder and ureters, resulting in fibrosis and calcification, causing hydronephrosis or cystic-like structures in the kidney, hydroureter, or dilation of the tubes from the kidney to the bladder and bladder neck obstruction. Disease manifestations correlate with the number of eggs produced by the worms. Severe disease is primarily seen in infected individuals between 10 and 30 years old. The urinary tract syndrome generally requires years of egg release to finally result in symptoms. Fortunately, many urinary tract abnormalities respond to anti-schistosomal therapy. Signs and symptoms of the urinary tract syndrome include suprapubic heaviness, urine frequency, dysuria or pain on urination, terminal hematuria or blood in the urine, straining and dribbling, and secondary infections. Cancer is occasionally seen. These cancers are primarily transitional and squamous cell cancers. Laboratory findings of the urinary tract syndrome include eosinophilia with a greater than 90% eosinophil count of white cells within the blood, and hyperglobulinemia. Serum is usually positive for anti-schistosomal antibodies. As with Katayama fever, eggs tend to be passed intermittently and in small amounts and may not be detected in the urine, so it may be necessary to perform a blood serologic test to help make a diagnosis. The microscopic slide shows the classic egg of Schistosoma hematobium with a prominent terminal spine. The cardiopulmonary syndrome is rarely seen in clinical schistosomiasis. Cardiopulmonary syndrome is caused by the embolism of eggs to the lungs, resulting in cor pulmonale. Cor pulmonale is the abnormal enlargement of the right side of the heart as a result of disease of the lungs or the pulmonary blood vessels. Fortunately, with appropriate therapy, remission of urinary tract symptoms occurs within 2 to 3 weeks, though this may occasionally take months. Schistosomiasis can occasionally cause central nervous system CNS symptoms. Schistosoma japonicum can cause focal cerebral granulomas. Schistosoma mansoni and hematobium have been associated with transverse myelitis of the spine. Central nervous system CNS signs and symptoms include seizures, paralysis, and inflammation of the spinal cord. Imaging studies like CAT scans and MRIs may be helpful demonstrating lesions. The imaging pictures on this slide demonstrate enhanced nodules in the white matter. The histopathological slide of a biopsy specimen confirmed cerebral schistosomiasis. This is a histologic slide of an ectopic Schistosoma japonicum egg in the brain. Eggs may rarely end up in other sites, but are usually clinically insignificant and may include fallopian tube, lung, pancreas, placenta, and testicle, etc. The picture on this slide is of a lung slice showing pseudotubercles in the case of fatal pulmonary schistosomiasis. Diagnosis consists of three essential parts. 1. Careful review of travel and residence history. 2. History of a pruritic rash. 3. Examination of feces, urine, and tissue specimens. And 4. Serologic testing. A careful review of travel and residence history is critical for determining exposure risk. Has a person traveled to or resided in a schistosomiasis endemic area? Is there a history of exposure to fresh water with appropriate snail vectors and where waters are potentially contaminated with human excreta? Exposure is usually associated with activities like swimming, bathing, washing clothes, etc. in contaminated waters. This history would indicate schistosomiasis risk not only for individuals living in endemic areas, but also adventure travelers to those areas. This picture is of the Dona Ana stream in Puerto Rico with footpaths leading through Cercaria-bearing waters. A travel and residence history also provides information regarding the schistosoma species that may be causing infection, as reflected in this table we previously discussed. Schistosoma mansoni is found in Africa, the Middle East, the Caribbean, Brazil, Venezuela, and Suriname. Schistosoma japonicum is found in China, Indonesia, and the Philippines. Schistosoma mekongi is found in several districts of Cambodia and the Lao People's Democratic Republic. Schistosoma intercalatum and its related species guyanensis are found in the rainforest areas of Central Africa. Schistosoma hematobium is found in Africa and the Middle East. Both Schistosoma mansoni and hematobium are endemic in some of the same areas of sub-Saharan Africa. So it's important to look for eggs not only in the feces, but also urine of individuals from those areas. A history of a pruritic or itchy rash is helpful. These are two pictures of a schistosomiasis rash. The rash is associated with the time cercaria from infested fresh waters penetrate the skin. Examination of feces, urine, and tissue and biopsy specimens for eggs is the primary method for diagnosing schistosome infections. Species of interest determines whether urine and/or feces should be examined. The choice of sample to diagnose schistosomiasis depends on the species of parasite likely causing the infection. Adult stages of Schistosoma mansoni, japonicum, mekongi, intercalatum, and guyanensis reside in the mesenteric venous plexus of infected hosts and eggs are shed in feces. Schistosoma hematobium adult worms are found in the venous plexus of the lower urinary tract, and eggs are shed in urine. Once again, it's important to remember that Schistosoma mannsoni and hematobium are both endemic in several of the same areas of sub-Saharan Africa. So patients with freshwater exposures in those areas should have both stool and urine samples examined for eggs. Testing of stool or urine can be of limited sensitivity, particularly for travelers who may have a lighter burden of infection, since eggs are shed intermittently and in low amounts in light intensity infections. To enhance the sensitivity of stool and urine examinations, 3 samples should be collected on different days. Even in asymptomatic patients, at least 1 stool or urine for eggs will likely be positive 3 months or more after exposure. Quantification of eggs provides information on the intensity of infection and risk of complications, and can be performed by using various processes like Cato's thick smear or the Bell nucleopore membrane techniques. Schistosoma hematobium has a diurnal pattern of egg excretion. Therefore, collection of urine specimens between 11 a.m. and 1 p.m. may increase detection of infection. For Schistosoma hematobium, the presence of hematuria, or blood in the urine, can suggest infection, but this test is more useful for population prevalence studies in Schistosoma hematobium endemic areas of Africa and is not sufficiently sensitive or specific for individual patient diagnosis. For intestinal schistosomiasis, if specimens are negative in a person considered highly likely to have schistosomiasis, a biopsy taken at the valve of Houston, located approximately 9 centimeters from the anus, may be helpful. Serologic testing for anti-schistosomal antibody is indicated for diagnosis of travelers or immigrants from endemic areas who have not been treated appropriately for schistosomiasis in the past. Common serologic tests used to detect schistosomiasis prevalence include enzyme-linked immunosorbent assays, ELISA, using 3 different antigens, an indirect hemagglutination assay, and an indirect immunofluorescent antibody test. For new infections, the serum sample tested should be collected at least 6 to 8 weeks after infection onset to allow for full development of the parasite and antibody to the adult stage. Serologic testing may not be appropriate for determination of active infection in patients who have been repeatedly infected and treated in the past because specific antibody can persist despite cure. In these patients, serologic testing cannot distinguish resolved infection from active infection. The presence of antibody is indicative of an infection at some time, or the prevalence of infection, but a positive antibody test can generally not be correlated with current clinical symptoms or incidence of a new infection. In a study by Hans Friederman et al., the sensitivity values for detection of schistosomiasis cases ranged from 41 to 78% and were higher for Schistosoma mannsoni than for Schistosoma hematobium infections. Specificity values ranged from 76 to 100%. False positive results were most frequent for samples from patients with cestode, flatworm or tapeworm infections. By combining 2 or more tests, sensitivity improved markedly and specificity decreased only moderately. Serological tests are useful instruments for diagnosing imported schistosomiasis in countries where the disease is not endemic. But due to limitations in test sensitivities, we recommend the use of 2 or more assays in parallel. Serology is most commonly used as an epidemiologic tool. An antigen test has been developed that can detect active infection based on the presence of schistosomal antigen, but this test is not commercially available in the United States and at this time is undergoing field evaluations for accurate diagnosis of low-intensity infections. Dosing and adverse reaction details are complex and beyond the scope of this session. For more dosing information, refer to references listed on this slide. The Red Book, Report of the Committee on Infectious Diseases, American Academy of Pediatrics, and the CDC treatment guidelines. Generally, treat only patients with eggs demonstrated, with the exception of patients highly suspected of having central nervous system CNS disease. Fortunately, complete regression of urinary, CNS, and other signs and symptoms of schistosomiasis are common if patients are treated when the disease is of relatively brief duration. This underlines the importance of screening individuals for possible schistosomiasis who have visited or reside in endemic areas, particularly if they have a history of exposure to contaminated water. Generally, Praziquantel is the drug of choice for all human schistosomes. Schistosoma japonicum and Mekongii require a higher total treatment dose than Mancini, Hematobium, Intercalatum, and Guyanensis. Occasionally, with heavy infections of Schistosoma mancini, for example, greater than 800 eggs per gram of stool, the higher treatment dose may be necessary. Oxamniquin is an alternative medication used to treat schistosomiasis in Brazil and Africa. Oxamniquin is not available in the United States. Cure is seen in approximately 77.8% of patients with Schistosoma mancini when treated with Praziquantel or oxamniquin. IgM and IgG antibodies to worm antigens may persist for 1 to 2 years after treatment. Resistance to Praziquantel has been reported in Senegal, West Africa. Oxamniquin should be used when resistance to Praziquantel is suspected. There are 6 major prevention measures to control schistosomiasis. The first 5 help control human to snail transmission and include effective case identification and treatment, regular mass treatment of populations with Praziquantel in endemic areas also has been shown to decrease schistosomiasis prevalence. Mass prophylaxis, or early treatment of disease for population groups in endemic areas with Praziquantel, has been used successfully over the past 30 years to control schistosomiasis in many countries. The goal of mass Praziquantel prophylaxis or treatment is to cure early infections to prevent severe late-stage morbidity and mortality. Treatment several times during childhood likely prevents disease in adulthood. The recent increased support for the control of neglected tropical diseases and increased access to Praziquantel led to a significant increase in the number of people treated for schistosomiasis. In 2012, more than 35 million people, 83% of them in sub-Saharan Africa, were treated for schistosomiasis. Experience from China and Egypt shows that preventive chemotherapy, mass treatment without individual diagnosis, with high coverage, can significantly impact schistosomiasis infection rates. Mass treatment is targeted at high-risk groups that are identified by public health prevalence data. Praziquantel is safe in pregnancy, and it is recommended that women and adolescent girls of childbearing age should be included in mass treatment programs. Target populations in endemic high-risk areas for mass prophylaxis include school-age children, adults considered to be at risk, including pregnant and lactating women, individuals in contact with infested water, such as fishermen, farmers, irrigation workers, or women completing domestic tasks like washing clothes, bathing children, collecting water for home use, etc. Very young children often become infected with schistosomiasis when taken to water contact sites by their caregivers and siblings. In some situations, the prevalence of schistosomiasis infection in these young children is very high. Recent studies have shown that Praziquantel, when made palatable for young children, is safe, well tolerated, and effective in the treatment of preschool children. Inclusion of very young children in mass treatment campaigns is a challenge, since there is no commonly available commercial pediatric formulation of Praziquantel. It is recommended that preschool children should be treated for schistosomiasis within child health care services where their weight is monitored, they're immunized, dewormed, and given micronutrient supplements. As expected, it's common to include entire communities in mass Praziquantel prophylaxis, since infested water sources are commonly used by every person in many communities. Provision of safe water and adequate sanitation will also help control human to snail transmission and reduce schistosomiasis infections. Cercaria can penetrate not only the skin, but also mucous membranes of the mouth. Therefore, provision of safe water is important. Measures to provide safe water include provide safe and protected water supplies for home use and control human sewage. Safe water may be provided by community water treatment systems. Provision of safe water supplies depends on the resources available to a community. For some communities, municipal water systems are possible. For many resource-poor or rural communities, protected wells and practicing personal protection measures are the only reasonable options. A common municipal water treatment method is illustrated in this diagram. Raw water is first coagulated and flocculated. Flocculation involves the addition of compounds that promote the clumping of particles so that they can be more easily separated from the water. Coagulation is a chemical process that involves neutralization of charge, allowing the particles to more easily settle out of raw water. Iron and aluminum salts are the most widely used during this step, but salts of other metals, such as titanium and zirconium, have been found to be highly effective. The water then goes into a mixing basin and then to a settling basin where the flocculated and coagulated particles settle. The next step is usually to fluoridate the water. Fluoridation of water is important to improve the dental health of a population. The water then passes through a carbon and sand filtration process. It is then treated with ultraviolet light, chlorinated, and stored. Often as diagrammed, corrosion control processes are applied to prevent distribution system deterioration. Obviously, this municipal water treatment system is not feasible for most rural or resource-poor areas of the world. Providing safe water for rural and resource-poor areas can be done. Safe water supplies may be significantly augmented by adequately constructing and protecting a community well as pictured. The well should be as deep as possible and the surface around the well protected with concrete as demonstrated to help prevent surface contamination. Even with these measures, it's wise to boil the water as an extra safety measure. Use of chlorinated or boiled water where protected community-wide safe water is not available is important. Sewage management is important and includes developing and maintaining community sewage systems. Like community water treatment systems, many communities lack the resources to build and maintain community sewage treatment facilities. Therefore, building cost-effective, ventilated improved pit VIP latrines can significantly control human waste and decrease human to snail transmission of schistosomiasis. Ventilated improved pit, VIP latrines, were a major strategy to control diseases like schistosomiasis and other human fecal oral diseases during my 12 years of community engagement work in East and Central Africa. Generally, VIP latrines cost about $12 to construct. Maintenance is minimal. As diagrammed, the airflow through the vent pipe not only vents offensive odors, but also effectively draws flies from the pit to the fly screen where they collect and die. Flies can transmit various fecal pathogens to humans by landing on eating utensils and food, etc. Prevention education is essential to help control risky behaviors. Prevention education topics could include avoid contact with contaminated water, like avoid swimming in infested water, wear waterproof boots when wading in water, prompt drying of any areas of skin contact with infested waters by vigorous rubbing, and alcohol may decrease penetration of the cercaria. Participate in mass Praziquantel prophylaxis programs. Protect home water supplies. Build VIP latrines. Boil and chlorinate water before using. Snail vector control is another schistosomiasis prevention tool. Elimination of susceptible snails by using molluscicides like copper sulfate, niclosamide, and pentachlorophenate has been used in endemic areas. Problems associated with molluscicides are significant and include adsorption of the molluscicide by particulate matter, photoinactivation and dilution of the agent, toxicity to fish, aquatic animals, crops, and humans, and the rapid repopulation of treated water by snails. It only takes a small number of snails to repopulate a water source in a short period of time. Controlling the snail vector is very difficult. The picture is of a man spreading molluscicide in a contaminated water source. This is an article from January 8, 2009 in the New England Journal of Medicine regarding a comprehensive control strategy to reduce transmission of Schistosoma japonicum in the Jiangxi province in China. The methods of control included annual synchronous mass chemotherapy with Praziquantel, remove cattle from snail-infested grasslands, provide farmers with mechanized equipment, improve sanitation, for example, tap water, lavatories, and latrines, provide boats with fecal matter containers, primitive toilets, and provide an intensive education program. The rate of human infection decreased from 5.1% in 2004 to less than 1%. Infected snails decreased from 2.2% to 0.1%. The authors concluded that a comprehensive control strategy to reduce transmission from cattle and humans was highly effective. Comprehensive approaches can decrease the burden and prevalence of schistosomiasis in endemic areas. In summary, schistosomiasis is fifth as measured by DALYs in global parasitic disease impact. There are 6 major species of schistosomes that cause a large majority of human disease. Humans are infected by free-living cercaria penetrating the skin or mucosal membranes. Schistosomiasis symptoms and signs are generally caused by the inflammatory response of the body to eggs located in or passing through tissues. Schistosomiasis transmission is enhanced by selective public health interventions. Examination of specimens for eggs is the primary method for diagnosing schistosomiasis. Comprehensive approaches to control can decrease the burden and prevalence of schistosomiasis in endemic areas.